Thank you so much, everyone. I would like to invite Dr. G.S. Murthy and Dr. Varsha Rathi on stage to moderate the panel discussion.
Thank you, Dr. Nilimal. I hope Dr. Hans has been patient enough. If you can log him on. Yes. Yeah, there is. Thank you for your patience, Hans. We just wanted to give you a taste of the old times in India. This is called the Indian Standard Time, so don't worry. I'm sure you're used to it. I'm sorry, I'm just joking about it. So it's a pleasure and an honor to introduce Dr. Hans Lindbergh, whom I've known now for more than 30 years. When I joined in the RP Center in 92, Dr. Hans was already here working on the watershed DAN PCB supported project, which is looking at supporting primary health centers with equipment, and then went on to develop the District Blindness Control Society. So Dr. Hans is the initiator of the DBCS concept, which they tried out successfully as pilot projects in 5 districts in India. The school eye screening module, which we all use widely across the country today, he is the one who initiated it from Dan PCB at that time. And the RAB about which we talk about so much, the first iteration of the rapid assessment of cataract surgical services, was again an initiative from Hans Lindbergh. So Hans is a medical graduate, has worked in many parts extensively, a physician who then did his diploma in community eye health at the International Center for Eye Health in London. He worked in Zambia for about 4 years and then worked in India, works remotely from near about Amsterdam, very close to Amsterdam. I forget the exact village, Hans, but also keeps in touch with the latest developments. The RAB repository, which is again his brainchild of putting all the RABs globally together, is again another initiative from Hans. So this country owes a lot to you, Hans, for your presence, your foresight, and I think it is an honor and a pleasure for us to request you to share your presentation and your thoughts with the L. Prasad Eye Institute group here, the Indian Institute of Management, Ahmedabad, and the Indian Institute of Public Health, Hyderabad, faculty and staff and researchers here. Over to you, Hans.
Thank you very much, Murthy. Too much honor to me. My slide set, I've sent my slide set. Are your staff putting it on or should I put it on?
Are you putting the slide sets on?
I don't see my slides coming yet.
Are you putting on the slides or you want
I can put on the slides myself.
Yeah, Hans, if you put on the slides and the control is with you.
Oops. Can you see my screen now?
Yes, Hans.
Okay.
You can put it into slide show mode at the bottom of the screen. Yeah.
Yes, screen is
So,
visible.
the next icon next to that. The icon next to that.
I'm missing my screen now.
At the bottom of the screen, there's a barrel icon. There's a barrel icon at the bottom of the screen, Hans.
Yeah.
And just click on that, it'll go into the slideshow mode.
Or you press F5. Or you may press F5.
F5, I can do F5 as well. It says I'm sharing my screen.
Yes. Maybe it's okay to just.
Yeah, so go ahead, Hans.
Can you see the slides now?
Yeah, we can see the slides. You can go ahead.
Thank you very much for the invitation. Thank you also for showing this very nice picture of my face, which is about 25 years younger version of me. It's very flattering. I was asked to say something about research to policy, how we managed to do that in the NPCB. Now, in order to give you a bit of a good picture of this, I have to take you back to the history of NPCB. The NPCB was started in 1976 as a centrally sponsored scheme in India. It was the largest blindness prevention program in the world in those days, but it had a strong focus on cataract surgery only. It was unique in the world that it had very strong epidemiological data. Mind you, this is about India itself and the major states, not at district level. Now, the government of Denmark, where I worked for, I'm Dutch, but I worked for the government of Denmark, was supporting the NPCB since 1976. And with, for those days, substantial money. 14 million in the first phase, which ran up to 1987, 15.4 million up till 1999, second phase when I was there, and for the last phase, another 14 million. It focused that support on the nationwide expansion of infrastructure, equipment for ophthalmic units, mobile units were supplied with equipment, training of PMOAs, and support to the central monitoring and evaluation cell. That was the first phase. When they started with the second phase, they wanted to have more, let me say it differently, they had difficulties getting the right bills. It was a reimbursement scheme. India had to supply invoices for all the equipment they supplied, give it to the embassy, and the embassy would reimburse the money. Now, the vouchers were not coming forward that quickly, so they decided that they need to have more staff in India to control this and to support this. That's when I was recruited for phase 2. Again, a lot of hardware support, but there was also a component of intensified inputs in 5 pilot districts. That was for me the most challenging part, the most interesting part. The other things were all left over to the engineering institutions which were involved in the NPCB already. Development of monitoring systems was also very interesting for me. And of course, establishment of a needed support unit. Now, this is the important thing. 1989, the government of India decided that NPCB should no longer be a vertical, 100% centrally sponsored scheme, but it had to be integrated into the district eye care, district healthcare, sorry. So eye care integrated in general district healthcare. This sounds familiar, isn't it? This is exactly what WHO is wanting now, today, after Vision 2020 scheme. Danida was asked to experiment with this new approach in 5 pilot districts, spread all over the country. One was in Basti in UP, one was in Purnia, Bihar, one was in Bandara district in Maharashtra, Tumkur district in Karnataka, and Salem district in Tamil Nadu. 5 districts. Characteristics of these pilot districts were that we had a district blindness control society established there. We employed a district coordinator. It was focused on intersectoral cooperation and evidence-based approach. Now, how do we get there? Sometimes things have to go wrong first before they go right. One of the problems with 5 pilot districts was that the money was sent from central government to those 5 districts, but it didn't arrive there. The reason was that health is a state subject, so the states were allowed to use funds at their own, the way they preferred. So they didn't always see what the importance of these district blindness control district programs were, these pilot districts. So in order to avoid money being diverted at district level by the state, we established district blindness control societies, and therefore the government could send money directly from central government to the district for this particular purpose. That worked well. Danida employed the initial coordinators for these 5 districts, and they focused on this intersectoral cooperation. Now, this is where my experience comes in from Africa. In Africa, in the 80s, district medical officers, and which I was in those days, were supposed to run healthcare in a district. So we were supposed to do a lot of planning together with the other development departments in a district. Of course, everything was much smaller. The district where I worked in those days had a population of only 220,000 people. Very small compared to India, where the average population in those pilot districts was about, it was 3 to 5 million people, much more. So the scale was different, but we had worked with that already before. Okay, district blindness control society. It took about a year before these were established and allowed us to send the funds directly from the center to the district. The funds were going there based on performance. It depended all on the output of the district, how much money they got. Hardworking districts could get more money. If you did less, you got less money. It was in fact a reimbursement of an initial amount of money they received. And from that they started working, and every time the money was finished and if the accounts were okay, they could get a new installment. District program coordinator was employed by the District Blindness Control Society. They could be hired and fired, a totally new thing in India, unheard of. But the district societies liked it. District level planning and implementation. This was the whole new thing, and we invested quite some efforts to really get this off the ground. Good cooperation with Government of India, NGOs, and private practitioners. It's crucial. Mind you, in many cases, an ophthalmologist worked during the day for the government. In the evening, some of them worked together with NGOs, and others worked as private practitioners. We needed all experts, all expertise in eye care. Also because it became controlled by the DBCS, the District Blindness Control Society, the involvement and visibility at district level was much higher. Now, let's focus on this district level planning and implementation. Before you know what you have to do, you first have to know what the problem is. And we did have a lot of data from national surveys and state level surveys in India. But when we translated this back to district level, just by the number of people living in that particular pilot district, we ran into problems because we had ophthalmologists there, and some of them were working for more than 20 years in that district, and they disagreed with what these numbers deducted from state level planning, what they told us. They told us we have either much more cataract or we have far less cataract. We have more vitamin A deficiency or we see less vitamin A deficiency. It became clear to us that we could not just bring it back from state level to district level. So we needed a kind of survey at district level in order to assess what the needs were at district level. Now, this was how the rapid assessment of avoidable blindness was born. we started with the standard WHO format. They had a kind of format used in surveys, but they never made any software to do the data entry or to do the data analysis of these formats. We used their format, but we found it too complicated and simplified this. This was one of the important lessons I learned in Africa. If you want to get things done, make things as simple as possible. So the original format was too complicated. We simplified it and started working with that. We focused on people aged 50 years and older. Why? Because 80 to 90% of all blindness and vision impairment occurs in people aged 50 years and older. So the prevalence is highest in that age group. With a high prevalence, your sample size can remain small, and it still is highly representative for the entire population. We used a standardized, robust epidemiological method of cluster sampling. The enumeration and the examination could be done in one day. We used inbuilt validation rules and automatic standardized reports. That means that the findings of these surveys are comparable worldwide because they all do the same thing. The calculations are all the same. Now, the first version was made in India, in the University of New Delhi, by Dr. Indine and his team. And it was made in AP-Info 4.0. A very small, very robust software package on epidemiology. We published this in 1997. These are some more publications which are concerning this survey methodology, and also one of the indicators which we came up with there, the cataract surgical coverage. This is now one of the major indicators used by the World Health Organization, in fact the effective cataract surgical coverage, to measure the impact of eye care services in the country. Now, most of you will be familiar with this. This is the Vision Atlas, which is including data from all over the world on surveys on prevalence of blindness and visual impairment. Nearly 50% of all the data in there now comes from RABS, a rapid assessment of avoidable blindness, which originated from India for the purpose I just mentioned to you. So this is what happened with the small size district level surveys which were conducted in the 5 pilot districts originally in India and later were accepted by the WHO and approved as the standard for blindness surveys worldwide. Now, what happened in those 5 pilot districts? What we saw was that the output in terms of cataract operations was increasing very rapidly, and that the government of India found it fully acceptable that a district like Salem and Tumkur, which were fairly well developed, that you could improve a lot there. But Bandara and even more Basti and Purnia, UP and Bihar, that was really a great surprise to the government. And they said, look, we want this method to continue. Now, in 1994, the World Bank came in with a very large and ambitious support scheme, much bigger than Danida had, about 10 times as big. And they focused on the 9 major, the largest states in India, which covered roughly about 70% of the Indian population. And they wanted the Danida approach with the district blindness control societies also in their districts to use that. 2 weeks later, government of India said, nah, becomes a bit complicated. We don't want 2 systems running in India. You know what? We fund the remaining 30% of India. So within 2 weeks' time, a 5-district pilot scheme was promoted to an all India, at that time, 500 plus districts new approach. And this caused some anxiety amongst our teams. Murthy knows this. We focused totally on training of all these district blindness control coordinators in those 500 districts. My whole project was turned upside down. Fortunately, I had some very understanding superiors at the Danish embassy who saw this as an excellent opportunity, and they fully supported this transition. And for about 2 years, we have been doing nothing else but training new district coordinators to supply them to all districts in India. That was how DBCS came into existence in India. That is how the RAAP came into existence. Now something else. We were busy with these extrapolations from the national surveys and also from our own surveys. And then we noticed that the first cause of blindness and visual impairment was cataract, but especially for visual impairment, the second cause was uncorrected refractive errors. And India was about the only country which had uncorrected refractive errors as a major cause of blindness and visual impairment. The reason for this was the definition of blindness in those days. In the 90s, the definition in India of blindness and visual impairment was vision measured with available correction in the better eye. The WHO in those days, and that was the ICD-9 version of since 1972, was defining blindness and visual impairment with the best correction in the better eye. We started based on the Indian definition. Sorry, I have to say different. With the Indian definition, you suddenly notice that you have a large problem with your uncorrected refractive errors. With the WHO definition, you don't see uncorrected refractive errors because you measure it only with best correction. After we started working with it in India, and we emphasized this a lot in WHO meetings as well, WHO came with an advice in 1998 to measure the best correction is still the definition, but measure it with available correction as well. And finally, at the ICD-10 version of 2016, the definition by WHO was changed into available correction in the better eye, just like it was in India. So India was far ahead. But because we saw such a large group of uncorrected refractive errors, we started, and especially in kids, we started a project to screen children in a more effective way. We had ophthalmic assistants, and officially they had to do school eye screening. But the number of the ophthalmic assistants was far too low to do this. If they had to do this every year, they would be busy for more than a year and were not having time for anything else. So we felt we need an extra screening level in there. So we experimented with teachers, whether they could use a simple screening chart just to find out whether kids could see a certain level or kids could not see it. A teacher's chart. We did a study amongst 1,158 students in 5 middle schools with the paramedic ophthalmic assistant with his Snellen chart and tri-lens set, a paramedical ophthalmic assistant with the teacher's chart, and a teacher with the teacher's chart. In this way, we could evaluate the materials, we could evaluate the examiners, and we could evaluate the PMOAs with the teachers and develop and find out how accurate they were in identifying a case or a non-case. Now, this worked out well, and we decided to go ahead with our scheme and expand this in one district on a trial basis. And the results were later published together with the screening system in World Health Forum in 1995. What we saw was that roughly about 5% of the cases, and we're now talking about children in middle schools, that mean 10 to 15 years of age, about 5% of these kids had were identified with poor eyesight by the teacher. 65% of those 5% were sent to the ophthalmic assistant. 17% was referred by the ophthalmic assistant to the ophthalmologist because of complicated cases. 43% to 2/3 of the 65 were prescribed spectacles. Of those 43, 95% were given spectacles by the optician, and 96% were wearing spectacles. Cost of screening of 46,000 kids, 1 rupee per child. Cost per child found to have a refractive error and provided with spectacles, 85 rupees. The most important thing was that teachers actually reduced the workload of the ophthalmic assistants with about a 20th, with a factor 20. So this made it possible for the ophthalmic assistants to really cover much more schools, nearly all the schools in the district, and still provide good services in terms of refraction and prescription of glasses. I won't go in, I don't have the time to go in all the details of this whole scheme. Most of you will be familiar with it because I understand it's still running in nearly its original form. We used in those days the cutoff point 6/9. WHO later used 6/12 in order to reduce the number of false positives. Now this is the system, how it works. At this moment, yearly, roughly about 30 million kids are screened, and over 600,000 spectacles are provided free by the government of India. Of course, there are many more children which are getting spectacles because the parents pay for it. It doesn't matter. As long as the children get the spectacles, I think we have achieved our goals. In 1994, before this publication, when we showed these initial findings to the government of India, they immediately jumped to this and made this an integral part of the NPCB officially. So again, I was warned when I came to India, mind you, there's red tape all over the place, but red tape, they are very quickly to tear red tape apart when the need is there. So the government of India jumped to it and made this an integral part of the NPCB in 1994, just as the DBCS was also integrated very quickly all over India. School eye screening, afterwards we came with more results and more controls of it. In 1999, we published an article on the results of 5.4 million kids screened in India. And later on, I participated in a publication on the cost effectiveness of screening and corrected refractive errors in school children in Africa, Asia, America, and Europe, which was very favorable. We got many more publications about the cost effectiveness at that time. A third one, cataract outcome monitoring. Murthy knows this very well. He was training ophthalmologists in community ophthalmology at RP Center. And I was teaching there also. And in publications, we knew that the results for cataract surgery in publication were always 90% or better. That means they could see 6/18 or better after cataract surgery. However, our surveys indicated that 25 to 50% of the patients operated for cataract could not see 6/60 after cataract surgery. Now, some of them were older patients, of course, which were operated with perhaps older techniques. Some of them, in those days, mind you, were couching patients, which were still occurring. I came across couching practices, especially in Purnia and Basti district. And the comment from the ophthalmologist present was always, I only see problems from colleagues. My answer was always yes, but realize that your colleagues see your problems. And this has to do with shopping by patients. If they're not happy with the performance of the doctor, they tend to go to another doctor because they're not satisfied. So for us, this was an indication that the quality of cataract surgery needed improvement in order to keep patients satisfied and to motivate patients to come for cataract surgery. I remember Dr. Venkataswamy, Dr. V from Aravind Eye Hospitals, used to say, if one patient is not having a good outcome, I need at least 100 patients to compensate for this, because otherwise they're unhappy. So we started experimenting with various systems, the telesheet system for small practices with not more than 100 operations per year, computerized systems, and apps. The apps is the latest, of course. It helps to identify the cause of poor outcome. And this is especially important for the doctor, him or herself, so that they can correct this. It is not intended to compare individual surgeons or clinics. That's not the way it should be used. It's important for individual surgeons and clinics to follow their own trends over time and to see where they can achieve better outcome. This is still a difficult thing. We've done numbers of trainings. There have been numerous publications on this, but it is still difficult to get people using this system. The latest one we have is an app which is collecting data in the cloud, and basically the individual doctor in updating his or her data into this system compares his or her results with those of all the other people in that same system. So you see your results benchmarked against all the others. It's called Boost. The Boost program has been made in collaboration with Aravind Eye Hospitals, and it is freely available on the internet. You can find it. Finally, the achievements of eye care in India. Cataract surgeries increased from about 1 million in 1990 to more than 6 million in 2016 and 17. I presume that by this time the numbers may even be higher, but this is the latest I could find. Cataract surgical rates increased from 1,000 to 5,000 per million population. Again, will be higher today. Nearly 30 million kids are screened for uncorrected refractive errors, and 600,000 free spectacles are provided every year. Indian ophthalmologists are pioneers in cost-effective and efficient systems to deliver eye care and are advising many of their colleagues abroad in other countries. This, I think, makes the difference. India is one of the few countries where other disciplines are involved in eye care very strongly. I'm one of the examples of it. Murthy is also one of the examples of it. We are not ophthalmologists. We are public health people who are interested in ophthalmology and can approach the whole eye care problem from a different angle. And lastly, this is what I feel could be improved. The government of India should be more visible on how they made this all possible. The government of India had made very important steps in making eye care in India so successful by expanding the DBCS scheme to all districts, by including school eye screening into the NPCB program, by including outcome monitoring, I think, and by providing the grant in aid system. I think India should be more outspoken on how they made it all possible in order to teach other countries worldwide what they can do in order to improve their eye care programs. I think in a nutshell, this is what I learned from my time in the NPCB in India.
Thank you, Hans. That was wonderful. And what it indicates is that if the basics are done correctly, then there are no issues. Then there are no issues in scaling it up. if you go wrong in the initial design and architecture, then you have the problems. And what you just described very clearly shows that if we put in the effort to design a program properly, then I think it has a great potential to be scaled up, though not in the way the DBCS was scaled up. Like Hans mentioned, we were all very apprehensive because we saw that there were districts which had performed well and districts which had not performed well. To scale it up using the two extremes was a risky proposition, and we saw that that risk actually derailed some of the gains during that particular period of the national program. I'd also just like to take on one more point that Hans mentioned, what he learned from Africa about keeping things simple. And that's how they eat an elephant in Africa, bit by bit, not the whole elephant at the same time. So that is something which is important. Simplify, demystify, and then look at taking it forward. Another of your old colleagues currently is still very active, Hans, is Sham, and Sham is here as part of the panel. So if Sham, if you could just join and you can just wave across to Hans. I don't know whether you can see him.
Yeah, I saw him.
Yeah. So what we are going to do is to look at following up the presentation that you're given, Hans, with a panel of two people, Dr. Shamanna, whom you know very well, and Dr. Praveen Vashish, whom you also know fairly well.
Yes.
Good afternoon, sir.
Good afternoon, Praveen.
Yeah.
Good to
Nice
see you again.
Thank you, sir.
Praveen is actually in Chandigarh in another meeting at the moment.